Hello.
Hi.
I have Dr. Riddhi Rathi with me, and she's orthodontist plus implantologist, and she's practicing since 2012, and amazing clinician, I can say. I've seen her cases. Yeah. So,
thank
Riddhi,
you, Doc. You have to meet this guy. He's Dr. Salman Ali, and he's from Riyadh. He's come all the way to Kochi to train people, and within the first 10 minutes, he is an exceptional researcher and a clinician. His cases are vibing. So you should follow him and you should work around him. Doc, I have one question to you.
Sure.
We're talking about failures. Of course, failures and failure management is a primary concern because when you start the practice, right, you just start placing the implants. You don't know whether it's going to last 8 years, 10 years, 15 years, lifelong, right?
Okay,
so
Riddhi, sorry.
I want to
if I tell you, you can predict the implants, how much it's going to last, even before placing the implants.
That was my question.
Okay.
That is my question, that how do you in your practice understand that when you see a bone or when you see a patient, after a thorough case history, how much the implant is going to last?
For me, I think the most important thing for implants is data acquisition. So first, you have treatments like you go for a CBCT. CBCT gives you a brief idea about the bone, what type it is, how porous, like D1, D2, D3, D4. Or if you're going for an immediate, what type will it be, what implant to select, more aggressive, less aggressive. So this is one. The second thing is occlusion of the patient. You know better about it. You are correcting everyone's. So occlusion is one of the most important part, restorative space, which is really critical. Then last but not the least, most people tend to forget about tissues.
I agree.
And the importance of tissue. So biologic width in implants, everyone knows about the biologic width. It's 3.5 to 4. Now imagine if someone is not respecting the biologic width, even without doing anything, they'll have a crestal bone loss, 1-2 millimeters. Right. So this is the most important, the critical part. Second thing is what type of implant you're using. Yeah. What type of connection, because there are some connections you are not supposed to place subcrestal.
Correct.
And this is just like
let's elaborate on that. So let's divide our conversation into 3 aspects. Say environmental factors, which are taken care of. Yeah, patient's factor, which are taken care of, and now comes to our dental factors. So let's say pre-surgical, surgical, post-surgical, prosthetic, and post-prosthetic. Yeah.
Okay.
So, Doc, I think let's start with pre-surgical. What do you think is the most important criteria?
I think the restorative space and the bone, amount of bone.
Well, I personally feel of course, the quality of the bone, the design of the bone, how much loss is there, do you want to graft it, you don't want to graft it. For me, very important question comes is what kind of occlusion it is there currently if the patient is dentulous, and if the patient is edentulous, whether he has removed tooth because of periodontal problem or bruxism. Absolutely. Or by negligence. So for me, that is the most defining factor pre-surgical.
I think the best thing, the patient's mouth says it all. Yeah. So the etiology of bone loss, etiology of tooth loss is the most important thing. Where the patient is losing the tooth because of caries, it's okay. If he's losing the teeth for perio, then there is a red sign or red flag. And the third one is it's a fracture, like abrasion. If the patient is like splitting the tooth apart from his occlusal forces, bruxism, so the mouth tells you everything.
Yeah.
I think.
So in a pre-surgical phase, what would be your most important criteria for deciding the design of implant?
I will say the most important thing for me is, see, I always say implant is an elective surgery. It's you are actually pushing it towards the patient. The patient is okay with the bridges, like most of them do if they're scared of surgery. But if you're thinking from an implant point of view, you have to take all the aspects into consideration. As you said, environmental factors, then dental factors, then the risk assessment for the patient, because you cannot place implants in older individuals. You cannot place implants in patients who cannot follow up with the treatment. Like, for example, You have done socket grafting today, the patient comes after 2 years, everything is gone.
Everything has been eaten up.
Now, the worst part is if you have an aggressive surgery, like if you've done an extensive grafting, and the patient disappears, and I hate to say this, but there is dehiscence.
Yeah.
There's the soft tissue has just opened up, the graft is just peeking out, so you will lose more bone.
Yes, and what also I feel when I think from pre-surgical is how much of vertical space I have, because that helps me in also understanding how deeply I would like to place an implant. If it is an FP1, FP2, FP3, FP4, what kind of number of implants I would need.
Absolutely.
Because if it's FP4, I would like more implants to be there because I have to compensate the crown to root ratio.
Also, I think the choice of prosthetic material, it's of key importance, because now, because of digitalization, and you are a digital practitioner, so you understand it much better how to play with materials. So I think progressive loading is one option. So you can choose composites,
Correct.
which is a softer material.
I
Then
agree.
you can shift to PEEK, again
yeah.
amazing material.
Lighter.
Cobalt chromium, then you can have titanium to reduce the weight.
Yeah.
Then you can have zircon if you want more aesthetics. And last but not the least, there are a few materials which I think are still under research, but they will soon be launched in the market. I think graphinano is there,
Definitely, yes.
and carbon fiber and glass fiber. So you have array of materials. So if you have an FP3 case, so instead of using acrylic, you can shift
We'll come
to
to
this.
that in the prosthetic phase. We've actually jumped spaces surgically. What do you think is the most important?
Surgically, I think patient compliance and the bone healing potential of the patient.
How much is that you can judge? Because see, bone healing, sometimes you look at a patient, right?
Age,
And
I give you the factors. Age, smoking, diabetes, systemic compromises like osteoporosis in
I
females.
actually beg to differ in that, because and personally in my practice, all my patients are between the range of 60 to 80. My oldest patient is 94-year-old. And what I have realized is the healing potential for these patients is as good as sometimes in youngsters. So for me, what I realize is that when you see a patient, it is very difficult to judge the healing potential. But of course, you can do some blood test and then you know, okay, that
is what I want, because you know most of the patients we are dealing, it's how much oxidation load they have. So this was a paper which was published by Dr. Joseph Chokaran, and he's the guy for the PRF, and they said that the bone healing potential reduces with age.
correct.
The set of and it also depends on the blood supply as well. So if
How
you
is
have
the
a
bone?
patient, how is the bone? It's a key factor for loading, deciding when to load, whether you have to go for progressive load or you can immediately load. So it's a key factor for the prosthetics for sure, and also for long-term success.
So